Hello once again, and welcome back to the Vox Pop WAMC's live afternoon call-in talk show. I'm Alan Chartock. Joining us today to discuss cardiology is Dr. Sankar Varanasi of the Hudson Valley Heart Center. In practice at the Heart Center's Poughkeepsie office, Dr. Varanasi is a fellow with the American College of Cardiology and a member of the North American Society of Pacing and Electrophysiology. A graduate of help me with that. Osmania. I'm so sorry. Medical College in India. Dr. Varanasi has completed fellowships in a variety of cardiology-related fields from General Hospital Center in New Jersey, Yale University, Norwalk Hospital in Connecticut, and the University of Wisconsin. Dr. Varanasi, you're a special guy. Welcome to the Vox Pop. Thank you for being here.
Thank you for having me.
Okay. To participate in today's discussion, everybody, 1-800-348-2551, 1-800-348-2551. You can also tweet us at WAMC Vox Pop or check in on our Facebook page, facebook.com/WAMC Radio. Okay, Dr. Varanasi, let's begin with what you do. You're you have a specialty in a specialty. You are not only a cardiologist, but you're an electrophysiology expert. What is that?
The clinical cardiac electrophysiology is a specialized focus area in cardiology that deals with cardiac arrhythmias. And it certainly includes certain procedures, what we refer to as cardiac ablations, implantation of pacemakers, and defibrillators that are utilized in managing patients with heart arrhythmias.
So if you've got an arrhythmia, there are several kinds of arrhythmias, aren't there?
That's correct.
They are?
So usually when patients, we categorize arrhythmias into two simple categories. So if you look at the heart as electrical structure or anatomic structure, it has two upper chambers and two lower chambers. The upper part of the heart drives the lower chamber. So the lower chamber of the heart is referred to as the ventricle. So we categorize them into two kinds of arrhythmias: supraventricular, that comes from above the ventricle, which are generally benign arrhythmias, and ventricular arrhythmias, which come from the lower part of the heart and have the potential to be life-threatening.
So when you walk around the malls, you see these boxes which say, they're electrodes, they can start your heart again. Who can operate those? Can anybody operate them?
That's a great question. That is one of the biggest problems in United States over the years. It is a medical term we refer to as sudden cardiac death, where a person collapses and can lose their life abruptly. And it's usually the consequence of a underlying heart condition, like somebody who suffered a heart attack and has recovered, or somebody who has had open heart surgery and survived. Or sometimes some people have genetic conditions. So their heart has a circuit that takes off suddenly under the right circumstances, unfortunate circumstances, and there is no blood pressure, so the person faints and collapses. And in that condition, the only thing that saves is a shock delivered to the heart. And that particular scientific concept is referred to as defibrillation. So these machines that you see in the mall, they're called automated external defibrillators. You see them on airplanes, and you see them in the malls and in schools. They're life-saving devices. Anybody can use them. They have an automated algorithm in there. You just put on a patch, one in front, where they recommend two in front of the chest, one in the high chest, one in the low chest, and the machine automatically analyzes the rhythm and says shock recommended or not recommended.
Wow. So also, we now see defibrillators being put into people so that they don't have to go bust the window down. They're already in them, yes?
That's correct.
How does that work?
That is, once again, they're implanted defibrillators, and patients are identified based on the risk for these arrhythmias, what I described as ventricular arrhythmias, and we identify them at risk for cardiac arrest. And these devices are run by a battery, and they have a very sophisticated circuit in the unit that is implanted in the chest. And they're connected to the heart using an electrode, which is also implanted through the veins into the heart, and essentially that makes electrical circuit between the defibrillator and the heart. And what the system does is it sends and receives signals from the heart. So it monitors your heartbeat, and it has the ability to recognize a normal and an abnormal heartbeat. And we have the ability to program certain features and tell the device, recognize this as a normal heartbeat and recognize this as an abnormal heartbeat. And the machine is always on. It's monitoring your heartbeat every beat by beat. And the moment it recognizes the heart has gotten out of rhythm, the machine charges and delivers a shock right into the heart.
Whoa. So you could actually get that shock without even knowing you're in trouble.
That's correct.
Wow. And so, well, I can just imagine the circumstances that could happen in. Now, doctor, you are qualified to put these devices into people, pacemakers and defibrillators, but you're a cardiologist, not a cardiac surgeon. How's that happened?
That's where the area of focus is. During cardiology training, we all learn about how to diagnose these arrhythmias and treat them with medications. And usually the treatment I'm referring to is with medications we refer to as anti-arrhythmic medications. So we do what we call additional fellowship, which consists of 2 additional years in our area of interest, where you are trained actually to be able to reach areas of the heart with small catheters that are placed just like somebody has an angiogram and has a stent placed. We have similar techniques where we utilize the veins in the body as well as the arteries.
So it comes up through the groin?
That's correct. Through the groin or through the neck, we access the big veins, and then we get into the heart.
So how many years did you have to study in order to get all this stuff done?
I would say probably altogether between college and everything, close to 17 years of postgraduate education.
Wow. When you do this kind of work, is it scary for you, or is it just as if you were, I hate to say this, an automobile mechanic? In other words, you've done enough of them so you know what you're doing.
Well, you know enough of them. You have done enough of them to know when not to do it. That is the most important thing. You have to know your limitations, number one. And it's matching the right procedure for the right patient. Whatever you do has to make a difference for the patient, meaning it either prolongs their life expectancy or it improves their quality of life. So then I think at that point, it is an acceptable risk that you put a patient through. And these are very sophisticated procedures. They have a potential to cause harm. That's why you have to become a cardiologist and then additional training. So you develop a respect for the procedures as well as the human body.
Now, there's some debate out there. I have a very good friend who just went through this, between having, you get a blocked artery and you now wonder whether or not to have a stent put in, which is a little tunnel, or to have total, cardiac surgery in which they take, the vein from another part of the body and put it in there. Where do you come down on that stuff?
Well, it is not by any means my area of expertise, but on the other hand, I have some general idea. Once again, it is derived by patient symptoms. And if the patient has symptoms that suggest that they are suffering from lack of enough blood supply to a certain part of the heart, they have symptoms like either angina or heart arrhythmias, unfortunately, in some circumstances, cardiac arrest. And those symptoms, based with some testing, what we call physiologic measurement of patient symptoms, and equating them with objective data, then we can make a decision, okay, this person is going to benefit from this. If it is usually pretty straightforward, one area of a blockage or 2 areas which are straightforward, my interventional colleagues usually can do a procedure called an angioplasty and put a stent in. But certain areas are complicated and certain patients are at higher risk for angioplasty. So in those cases, but we think the patient would do well long term by restoring the blood flow to the area. That's when we would recommend bypass surgery.
1-800-348-2551, 1-800-348-2551 for Dr. Varanasi. You couldn't do better. You couldn't find a smarter guy. If you have a question, now's the time to call. Right now, there's nobody on the line, and we certainly expect that by the time we get back, all of them will be on 1-800-348-2551.
Support for WAMC comes from St. Francis Hospital and Health Centers, Poughkeepsie, serving the healthcare needs of the community, including trauma and emergency care, and the Center for Robotic Surgery, sfhospital.org. The Unitarian Universalist Congregations of the Capital Region, teaching children how to make a difference through social action and volunteerism, capitalregionuu.org. Identity Eyewear Albany, customized eyewear fittings, European frame lines, and more. Identity Eyewear, it's what sets you apart. EYE-identityeyewear.net. SUNY New Paltz Distinguished Speaker Series presenting Amy Walden, author of The Submission, a novel about a Muslim American chosen for a 9/11 memorial design, November 1st at 7:30. newpaltz.edu/speaker series. And R.J. Stables, Hadley, Massachusetts, locally owned dining establishment since 1960, open for breakfast and lunch until 2, offering homemade breads, cookies, and pastries. Parking available, 413-586-4305.
And we are back with Dr. Varanasi on Facebook. Tommy on Facebook asks, can you see a heart attack on an EKG? What do you think?
Most of the time you can. Yeah, EKG is the commonly used, but usually if patient is having symptoms at the time EKG is performed or within a short duration of it, you can do it. But if patient is having a typical symptoms of EKG, for the most part, you can pick it up on EKG.
Let's go to Kay in Albany. Okay, Kay, you're on. Go ahead. Have at it.
Hi, thank you.
Sure.
My question is this. My mother had a pacemaker at about 69 years old, and her mother had one previously in her mid-70s. And I understand there's a genetic component. I was wondering if you could tell me a little about that, when I should anticipate my potential problem and what I should be looking for.
Usually the familial history comes in for a particular heart condition that prompts the need for a pacemaker. Pacemakers are implanted for several reasons. So if there is a particular familial condition that puts somebody at risk for a slow heartbeat, or there are some kind of arrhythmias, what we call atrial fibrillation, and there we use medications in combination with a pacemaker. In those circumstances, usually there is a familial tendency. And usually a regular physical checkup with the physician will be able to pick up. And as you get older, definitely a regular screening physical exam should be able to pick it up. And then appropriate referral to cardiologist.
Okay. Say the name of that exam again that you'd suggest?
EKG, a routine EKG.
Oh, an EKG. Okay.
Yeah.
Kay, thanks.
Okay, thank you.
Thanks very much, Kay. Appreciate it.
Bye.
Okay.
Mm-hmm. Bye.
1-800-348-2551. Let's go to Tommy in Neversink. Okay, Tommy, you're on.
Hello. I was wondering if you can see a heart attack on an EKG, because I've been in the hospital a few times for heart things, and they make me wait around for a blood test, sets of blood tests that take, a day. And then somebody says, well, they can just see it on the EKG. So I'm confused.
A good question. This is a very good, important public service question. I hope a lot of people are listening to this. The standard recommendation or the definition of a heart attack is where you have 2 of 3 positive signs, where you have typical symptoms or abnormal EKG and abnormal blood test. I want to elaborate for a quick second on the abnormal blood test. When somebody is having a heart attack, a portion of the heart muscle is going through irreversible damage. So when heart muscle is damaged, it releases its contents, what we call as enzymes, into circulation.
Right.
And nowadays, the sooner you get medical attention when you're having a heart attack, the better the outcomes, meaning there are no long-term complications and patients do well. So for that reason, there are a lot of tests that are designed to pick up a heart attack early. So it's not uncommon when you go to a hospital, they'll draw a blood test and they'll say it is normal, but you have to wait for 1 or 2 more, mainly because sometimes the test is not able to pick up the abnormality within 4 to 6 hours after somebody's chest pain or heart attack symptoms start. So it is true of all those things, but you have to have a combination. The EKG is something you have to use in combination with symptoms. There are different kinds of heart attack where it is really apparent. You can tell for sure just the EKG alone is diagnostic. But sometimes EKG can be limiting. It may not be diagnostic.
Tommy, if you don't mind, I want to ask a question on top of that. I have a first-degree relative who walks around with chopped up aspirin in his wallet because, you're supposed to take aspirin. Is that a good idea, doctor?
Absolutely. If you're having signs of heart attack, American Heart Association has done a phenomenal job, and a lot of patients do it as well. They have signs before they call 911. They take aspirin, a full-strength aspirin or 4 baby aspirins, and then call 911. Aspirin has been shown to really improve the outcomes in patients who are at risk or suffering a heart attack.
And along Tommy's question, how long does one, you say it should be done as soon as possible, get to the emergency room?
That's correct.
How long do you really think is the optimal time?
The optimal time to come to a hospital?
Yeah.
Well, the heart symptoms are usually very dramatic. The heart is the main chamber, main organ in the body. And when somebody is having symptoms, they just do not feel right. Some people don't have typical chest pain. Some patients have jaw pain, shoulder pain, pain between the shoulder blades, or sometimes nausea. Or typically in women and diabetics, they have what we call atypical symptoms. So you feel something that is different. It's a new symptoms. And if you are at risk for heart problems, you should not wait. And you should not drive to the hospital. You should call 911.
Okay. Tommy, thanks for the call. Appreciate it.
Thank you.
Okay, let's go to Dick in Longmeadow, Massachusetts. Okay, Dick, you're on.
Yes, thanks for taking my call.
Sure.
I was wondering if the doctor could explain the term ejection fraction and its relevance to cardiac function.
Yes, sir. Ejection fraction is the ability of the heart to function as a pump, as a mechanical pump. So it's a fraction that estimates a percentage of the heart's pumping ability. For example, if you look at the heart, the ejection fraction mainly refers to the left lower chamber of the heart, what we refer to as left ventricle. Suppose you say it's a pump and you fill it up with 100 ml of blood. With each beat, the normal heart should pump 50 to 60 ml. We refer to that as normal ejection fraction. It's not 100%. There's always some blood left behind after a heartbeat. So the ejection fraction refers as a percentage of the amount of blood that is pumped with each beat into circulation. So normal is 50 to 60. And once it is less than 50, that's when people start having problems.
Okay, Dick?
Thank you very much.
You're welcome. Thank you. Let's go to Kenneth in Oneonta. Kenneth, you're on.
Hey, thank you for taking my call.
Sure.
The doctor has mentioned a couple of times about not knowing when not to do a defibrillator pacemaker. And I'm wondering if you get a recommendation, how important it is to get a second opinion. My situation is I have my sister-in-law suffered a sudden cardiac arrest, and she had a serious anoxic brain injury. And the doctors afterwards said, well, she may recover some memory, she may not, but we recommend a defibrillator so that she doesn't have a second occurrence. And there was another doctor who said, don't bother. And I'm just wondering what the doctor thinks about the second opinion.
Second opinions particularly are very helpful when there's an area of controversy and if there is hesitation. And I'm very sorry to hear about your sister-in-law. That's very tragic. Some people do recover their brain function, and sometimes it may take up to 6 months or even a year. It all depends on how young the person is. And usually when somebody has suffered a cardiac arrest, they are at a much higher risk to suffer a second cardiac arrest within a few months. So that is why we recommend implanting a defibrillator. So second time, if they suffer a cardiac arrest, their anoxic encephalopathy or brain damage does not get worse with the second cardiac arrest. And it's a medical dilemma. It's also a ethical dilemma. But it is something you have to make in conjunction with the family doctor, which usually helps, who knows the person very well before and after the cardiac arrest.
But look, we're going to all die.
Yeah.
Many of us will die of heart attacks. You say, okay, somebody has a heart event, put in the defibrillator before the second in some cases. Why not put in the defibrillator for everybody before the first once you get to be my age, like 70 years old? Say, okay, sooner or later, I'm going to have a heart attack. So why wait until I have the first one and play that kind of, Russian roulette?
Well, I just want to clarify that when we use the word heart attack, the word gets mixed up, but a pure word heart attack means typical chest pain, going to the hospital and suffering damage and EKG diagnosing it. Defibrillators are not really used for heart attacks. They're used for dealing with the consequences following a heart attack. So, good question, but on the other hand, they have their own set of problems. Number one, so again, it's matching the right treatment to the right patient. And the second is the huge economic burden that goes with these devices.
Yeah. Okay. Hey, Kenneth, thank you very much for your call. Appreciate it.
Thank you.
Welcome. Okay, let's go to AG in Middletown. Okay, AG, you're on.
Okay, thank you for taking my call. My question, my mother had recently stent placement, and the heart doctor said, do not stop the Plavix without asking him under any circumstances. I just want to ask, why is that?
A good question. When somebody has an angioplasty and a stent, it is a foreign body within the heart, and sometimes it can promote clotting within the foreign body. And aspirin and Plavix are essentially, or the drug referred to as clopidogrel, they're both drugs that have been shown to minimize the clotting up of the stent. So once the stent is in place, depending upon the circumstances in which the stent was placed, as well as what kind of a stent was placed, there are certain recommendations you have to follow. There's a minimum amount of time that you have to continue the aspirin and the Plavix uninterrupted so that patients do not develop a clogging up of the stent. Otherwise, they would end up with a repeat heart attack or they would require another procedure.
Does that answer your question? Yeah.
That wouldn't be indefinitely, so just for a period of time.
That's correct. It's something, that's why one of the important things is there's a question you have to write down, ask the doctor how long does he think this needs to be continued.
Thank you very much.
Thank you, AG. Okay, 1-800-348-2551. There's one free phone now. Let's go to Sheila in Petersham. Okay, Sheila, you're on.
Hi, thank you. My father has a very long history of cardiac events and heart disease. He's actually from India himself. He's had multiple stents put in. He's had multiple other events as well. This summer, he endured a sort of a complicated heart attack. It initially presented itself as not a heart attack. As the doctor was saying, it didn't show up in the EKG, and it was complicated by an esophageal tear. He ended up in a fairly big Boston hospital for about 10 days, and they attempted to put a stent in at the end of his stay, and they were unsuccessful. A few weeks after that, during his recovery, he passed out during a family party, and he had extremely low blood pressure. Right after that, the doctors had asked him to have a one-day monitor put in, which didn't really find anything. But he's now had, it was suggested that he get a 30-day monitor put on with the possibility of getting a pacemaker. So I guess what I'm wondering is, with all that going on, what we should be looking for in this 30-day monitoring, and how concerned we should be that the stent procedure that they attempted this summer, which would have been a stent within a stent, failed. So they essentially didn't fix the problem that they think caused the mild heart attack, which it was a heart attack, and they don't know which came first, the esophageal tear or the heart attack.
Okay. That's a very complicated history. I think I have to address two questions differently. One of them is the issue of the stent that could not be placed. Again, this goes back to deciding whether the patient really needs one, and there are two ways to decide that. One is usually what we do, go by symptoms. Patient has to be able to do certain amount of activity, and if they're able to do that without having any issues like angina, what we refer to as chest discomfort or trouble breathing, or if they have any of those symptoms, sometimes a stress test is recommended to see if this is actually translates into objective data. And then there's enough information for somebody to say, okay, something needs to be done. And there's a good possibility this might have already been done during his stay in the hospital. Mm-hmm. And for one area that you cannot really get to, it's usually too aggressive to recommend open heart surgery. So I would not. So there are two options there. Either go back to put the stent, which has already been done, and they may not be able to do it regardless. The second option is bypass surgery, which would be too aggressive. So sometimes the doctor may decide it's not a big area to worry about and may decide to just treat with medications. Now, the second question is about his fainting, and a 30-day monitor usually is done to pick up heart arrhythmias. When somebody with a heart condition faints, we worry about either slow heartbeat or a fast heartbeat. Of course, they can still pass out because they're on so many heart medications which can drop their blood pressure. So these are all diagnostic possibilities a cardiologist will have to look into. And a 30-day monitor will give you that ability to screen for slow heartbeats or fast heartbeat and determine the future course of management.
Sheila, that's a pretty comprehensive answer. Thank you very much for calling. Appreciate it. Yeah. Okay. Let's see. That's off. All right. Let's go to Jane in Pittsfield. Okay, Jane, your turn. Go ahead.
Hello. Thank you for taking my call.
Sure.
I'm 75, and I've been diagnosed with atrial fibrillation for probably about 5 years. When I first had it, I had no symptoms at all, and it's been handled by medication. But the last 6 months or so, I mean, we've steadily upped the Sotalol, and the last 6 months or so, I see I have trouble, anything that's like stairs or a hill or something that causes more exertion, I'm really out of breath and it's hard to do. Beyond that, I live a very active life. And the cardiologist said he really can't raise the medication anymore. So I want to know what you think about ablation.
Ablation is a procedure that is quite complex and complicated. And it's very important to acknowledge that this is a procedure that is not aimed at curing fibrillation. Ablation is usually recommended for patients who are symptomatic with atrial fibrillation. And if your first diagnosis, your atrial fibrillation was asymptomatic, sometimes it's a decision you have to make in conjunction with your cardiologist. Really, how much of your symptoms can you attribute to fibrillation? If your symptoms are truly convincingly due to atrial fibrillation, then ablation is an option. But if it is not,
I'm not staying out of fibrillation anymore.
You're not.
No.
Okay. And sometimes you may be experiencing the side effects of the medications as well. And there are several options on the menu, and that is something you can discuss with your cardiologist and discuss the ablation. And sometimes pacemakers also play a role into it. And that is also a discussion you should undertake with your cardiologist.
Now, you do ablation, don't you, Doctor?
I do.
And exactly what is it again?
Ablation is essentially a process where you enter the heart chambers and you cauterize areas of the heart that you think are contributing to the circuit, causing the arrhythmia.
And what does cauterize mean again?
You use different kinds of energy and you're destroying cardiac tissue.
I see.
Controlled destruction of tissue.
Okay. Well, Jane, thank you for calling.
Okay, thank you very much.
Yeah.
Bye.
Okay, and let's go to Josephine in Dutchess County. Josephine, you're on.
Yes, I'd like to ask about something that was done when I had my heart attack a little over 2 years ago. I had 4 stents put into, I'm not sure where they put it, but I'm looking at the card that I was told to carry wherever I go, and it's called cobalt chromium. I guess that's the material that the stents are made of. Is that correct?
That's correct.
Yeah, and I had 4 of them implanted, and I'd like to know, is there any chance of those things moving once they're in? I mean, can they move around and go someplace where they're not supposed to be? I mean, how secure are they?
Extremely unlikely. What happens is after the stents are in place, after several weeks, the body forms a coating on that, and as time goes by, they become part of the vessel wall or the wall of the artery. So they're unlikely to move.
Okay, now that was, well, let's see, 2010 in July I had this heart attack, and I'm still very, I feel, well, that I haven't recovered as much as I should have by this time. One of the things that disturbs me, and I understand Jane said the same thing, that she gets breathless, and sometimes I get breathless just talking, but any kind of exertion, I lose my breath.
Okay.
Is that normal?
It's not normal, but it may depend on several factors. Usually when you go into a hospital with a heart attack, you're discharged home with multiple medications. Medications can be a factor. The degree or the extent of the heart attack can be a factor, because essentially a heart attack can leave somebody's heart damaged, that the heart is not able to pump as much as it did before. That could be a part of the heart attack.
Yeah, I think that was probably it, because I ignored my symptoms for almost 12 hours because I thought it was just a hot night, and I was doing some heavy work around the house, and I was perspiring, and I blamed it on that. I had no pains any place. The only time I realized that something was terribly, terribly wrong was when I broke out into a cold sweat so profuse, and normally I don't perspire very much, but I broke into this cold sweat to the point where my hair was dripping. That's how wet everything got.
Yeah.
And then I said, something is definitely wrong.
Okay, we got to take a break here, but Doctor, you want one more sentence or so?
Yeah.
Okay.
That's a typical we worry about in women with heart attacks. But again,
I had no symptoms at all.
Okay.
You need to just sort of sit down with your doctor and explain your symptoms, and I have to look at all the possibilities, like I mentioned.
Yeah.
Can I ask you
Josephine, unfortunately, we're up against a hard break
I'm sorry.
here.
I'm sorry.
That's okay. We thank you very much for calling, and good luck to you.
Thank you.
Yeah.
Bye-bye.
Okay.
Support for WAMC comes from the Hudson Valley Heart Center, providing cardiovascular care throughout the Hudson Valley with services including nuclear, echo, CT angio, and vascular testing to help evaluate cardiovascular wellness. hvheartcenter.com. Adelphi University's Hudson Valley Center, Poughkeepsie, offering a graduate program in social work and graduate and undergraduate programs in nursing. Adelphi.edu/Hudson Valley. The Linda, presenting singer-songwriter Melissa Ferrick, Friday, November 2nd at 8 p.m., thelynda.org for more information. And Athos Restaurant Albany, serving classic Greek cuisine, weekly specials featured on a 3-course prefix menu, dinner served daily, live music every Friday night, athosrestaurant.com.
And we are back. We are delighted with our guest today, and he really is extraordinarily knowledgeable. All the phones have been jammed, so folks, if you could keep your questions short, more people will be able to get in. Let's go to Nancy. Okay, Nancy, you're on.
Hi there.
Hi,
Thanks
Nancy.
for taking my call.
Sure.
I have a question. Back in 2007, I had an EKG, and in every subsequent EKG, right at the very beginning, something tells the doctor that I'm with that I've had a heart attack in the past 2 weeks. And I say, well, no, I don't believe that I have. And well, anyway, they did a nuclear stress test on me, and they checked my heart for about 20 minutes as it was pumping. And they said they didn't find anything. I have never had a heart attack, and I don't have any symptoms of heart disease. and that was the end of it, and that was in '07. But every subsequent EKG I had, the doctor says, I'm sorry, you've just had a heart attack. So I wonder, is this normal?
Okay, Nancy, we'll get an answer. Go ahead.
EKGs being categorized as normal are based on observations in several people who don't have underlying heart disease, and their EKGs look a certain way. And recording of an EKG is limited by several variables, where you put the EKG leads in men versus women. And sometimes it's not uncommon, particularly in women, the part of the heart where the EKG is being recorded, there is breast tissue. So EKG is essentially a recording of the electrical activity of the heart. If the electricity has to go through more body mass, the electrical amplitude recorded on EKG goes down. That usually is also a suggestion of a heart attack. So when there is no prior EKG to compare with, the first time you see somebody, you're concerned about it, saying that if the person has the right risk factors, you have to look and make sure this person is not at risk for suffering another heart attack. That's why patients go through all this testing. But once that question has been asked and answered, going forward, the EKG will pretty much look the same way. It's worthwhile having that EKG record somewhere in place. So if a new doctor or somebody new is looking at it, you can tell them and they can pull the previous EKG and compare it and say, okay, no new changes. Gotcha. And that's going to be your normal EKG.
Nancy.
Oh, great.
Thank you.
Thank you.
Bye.
Thank you.
Yeah.
Bye-bye.
Let's go to Liz in Boyceville. Liz, you're on.
Yes, thanks for taking my call. My husband, over the last year or two, started suffering from tachycardia, and I want to ask about triggers for tachycardia. He's now on medication and also had sleep apnea and is on a sleep apnea machine and seems to have improved it, but occasionally he gets he feels like it's starting. And two triggers seem to be related. One is his position. If he's sitting on the sofa and he slouches, it happens sometimes. And the other is eating a large meal. And I wanted the doctor to comment on triggers for tachycardia.
Dr. Varanasi?
Tachycardia is actually refers to a fast heartbeat. And different patients have different triggers. Some people can trigger it by simple things like bending down to plug a power cord into a wall outlet. And sometimes patients who are just standing, sometimes patients feeling nauseous and sick to their stomach. So there's different triggers in different people. Now, specifically, one of the things, observations that has been made over the years is these triggers usually cause sudden changes in the blood returning to the heart and getting pumped out of the heart. So essentially what you have is if you have, for any reason, more blood coming into the heart suddenly has to expand to accommodate that extra blood. And when there are mechanical changes in the heart, that changes the electrical properties, and that can trigger an arrhythmia. And also,
should you avoid these things?
Well, the answer is in your question. Like you said, the second one, avoid eating large meals, space them out, smaller meals.
Right.
And, that's one easy solution, practical solution. And the second thing, posture is going to be very hard, but as much as you can do about the posture.
Okay.
That's my problem. Thank you very much, Liz. Appreciate it. Okay. 1-800-348-2551. 1-800-348-2551. Waiting for your calls. Let's go to Jennifer in Savoy, Massachusetts. Okay, Jennifer, you're on.
Can you hear me okay?
We can.
Thank you for taking my call. I was just calling to talk about Alan's comment about the possibility of using a defibrillator so that an event doesn't occur later in life. And I just wanted to talk about, when I was 31, I had a MI with a right coronary artery dissection. And whenever
Wait. An MI for the rest of us is myocardial
infarction.
Yeah. Which
also
is
a heart attack.
Yeah. Go ahead.
When I did finally, when all was said and done and attended my cardiac rehab, I saw about 100 other patients during the time I was there. And I was the only one out of that group of 100 that actually had a heart attack. So I think it's very positive how well the news is getting out there and people are being pre-treated before these events happen.
Yes. Again, heart attack is the end point of cutting off blood supply to a portion of the heart. That can be due to several reasons. There are several different patients have different mechanisms that leads to these heart attacks. So in some young people, we call it a coronary dissection. In some people, we call the cholesterol buildup, what we refer to as atherosclerotic plaque, rupturing and causing a acute cutting off of blood supply to the heart. So different mechanisms. So I think it's very important to disseminate the information. If you, for any reason, if you have symptoms that suggest a heart attack, just like our previous speaker said, she was not well for 12 hours, she was profusely sweating, that is not normal.
Right.
Something.
No, I was just going to say my perspective on my whole event was that the news is getting out there and people are definitely being pre-treated and not having these cardiac events. And that it was just very, very optimistic that most people were there as a diet or a regimen-based cardiac rehab versus having a full event.
That's correct.
It's very, very exciting.
It's a great role in what we call risk factor modification and preventing or correcting risk factors as much as we can. And one thing I want to make sure that we get the point out there is heart disease does not discriminate. And just like you said, nobody should say you're too young to have a heart attack.
Right.
Thanks a lot.
Thank you.
Bye-bye. By Facebook, Jennifer and Troy asked, is there a correlation between heat flashes, atrial fibrillations, and insulin resistance?
It's a very complex question. They often coexist, so it's very hard to tease them out. But heart flashes usually are related to hormonal fluctuations. And it is very well known in the perimenopausal period, women tend to have more arrhythmias. Generally, they start several years before the menopause and can persist for a few years after menopause, and they go away like they came. So arrhythmia, like atrial fibrillation, is one of the arrhythmias. Certainly, it's not a very commonly reported arrhythmia with heart flashes, but it is possible.
Okay. Let's see. Where are we? You think I know? Okay, so the next question is, there was just a major report in the papers about, people who I think had type 2 diabetes, and the question was whether exercise and diet could help you if you were, you had extra weight. The answer was no. What do you make of that?
One study raises a question. One study is not the answer. It raises a hypothesis. It raises a hypothesis that needs to be questioned. And the concept that has been around for years is in diabetics, weight loss and exercise helps prevent heart attacks, but it also can reduce a lot of diabetes-related complications. I don't think we should change what we have been doing, what we consider good lifestyle modification based on one study. It should be repeated. It should be reproducible in several studies before we can draw a conclusion.
Thank you, Doctor. Let's go to Al in Hopewell. Okay, Al, you're on. Hey, Al, are you there? Whoops, maybe not. Al, are you there?
Can you hear me?
Yeah, we can.
Okay, I normally have very low cholesterol, 162. I was diagnosed with coronary arterial disease based on a nuclear stress test. And so I was put on medications, and I've been watching my diet and so forth. Now, 3 months later, my total cholesterol is 109. My LDL is below 50. When is cholesterol too low? I know it's important to have some.
I don't think there is a number cut off for calling it too low a cholesterol. And usually when we look at cholesterol levels, we look at total cholesterol is a good indicator, but we look at what we call different fractions of cholesterol. The LDL, also referred to as the bad cholesterol, and the HDL, that is referred to as the good cholesterol. In patients who have documented coronary artery disease, either with a heart attack or angina, or sometimes we just don't diagnose it with just abnormal stress tests, usually require further investigation, but sometimes stress test alone is good enough. In that situation, even though your total cholesterol is low, the sub-fractions of cholesterol may be abnormal. And there, the primary target for treatment is the LDL, and the recommendations are to keep it less than 70.
Well, my LDL is 49.
Okay.
So it's well below. It was 100, but it's down to 49, which is well below 70.
Well below 70. So, I mean, you're, I would say, at ideal levels, but it needs to be monitored every 6 months. And if you make other risk factor modifications like diet modifications, and if it continues to come down, then probably there is room to adjust your medication, and that is something you have to discuss with your cardiologist.
Al, got to let you go. Thank you very much. Let's go to Kurt in Schenectady. Kurt, you're on.
Yes, hi. I'm 50. About 5 years ago, I had quadruple bypass thanks to genetics. A stent put in about a year ago. But I've always been very active, and recently I've been doing a lot of long hikes in the Adirondacks, 15 miles or so, very strenuous. And my wife worries a great deal about me doing these kind of activities. I feel great. Is it safe for me to be going off and doing this kind of activity after the surgeries I've had?
Exercise has always been shown to help heart disease. There is no question about that. But there are several variables. Sometimes we want to make sure when you pursue this are safe. And that is something you need to discuss with the cardiologist. He has a lot more medical information about you available. If there's really no contraindication, exercise only can help your heart.
Well, but I think to some degree, Kurt makes a very good point. If you're out in the woods, in the Adirondacks, and there's nobody else around,
right.
Maybe if you have to do your exercise, you'd be better off, walking around the block 1,000 times.
And again, that's why a person who knows you best is the one in the situation to advise you.
Like your wife. Thank you, Kurt.
I was just going to say my wife. Thanks very much.
Kurt. Bye. Let's go to Dennis in Saugerties. Dennis, you're on.
Good afternoon. Thanks for taking my call.
Sure.
I have a question regarding both myself and my wife, and I do have permission to speak on her behalf in this case. We both have gone for routine physicals recently and both had elevated cholesterol. Now, in my case, I have a history of sick sinus syndrome and have had a pacemaker since 1982. My wife's case, she had elevated blood pressure and had that for quite some time, but it was not being treated with medication. The doctors have put us on 2 different medications, and we're kind of curious why the 2 different ones. We thought our cases were fairly similar. My wife was put on a Lipitor generic, and I was put on simvastatin.
Right, simvastatin.
And we're just kind of curious why the differences.
A person's cholesterol is determined by 2 factors, genetic factors as well as what to consume. You may share what similar foods because your family and you eat similar kinds of food, maybe some variation. But the genetics can be similar, and the degree of reduction of cholesterol, the targets may be different in different people. So they probably picked one statin that is stronger than the other for one person and not the other one.
Okay, super.
Okay, thanks a lot. Appreciate it. Let's go to John in Schenectady. Okay, John.
Yes, hello. I'll ask the question and then get off so you can answer it.
Well, only, John, because we only have minutes left. Go ahead.
Hey, real quick. I'm a marathon runner.
Yep.
And I have very low resting heart rates to the point where they're almost debilitating mid-afternoon. Sometimes I can have a heart rate around 44 or 45 and feel like I'm about ready to fall asleep at my desk. So just wanted to get some input on that, whether that's serious or normal as I've heard it is. Thank you.
Heart rate, one number does not make it. We usually recommend that we exclude other reasons why somebody would have a slow heart rate, even though you're a marathon runner and you could have a slow heart rate. But other conditions, for example, thyroid conditions, slow thyroid can make the heart rate slower. So you need to make sure you don't have anything like that. And sometimes if there are any medications, and sometimes just a resting heart rate alone is not enough to call it abnormal. We usually recommend evaluating your heart rates with exercise. And once again, something to discuss with your doctor and come to a conclusion about whether you need any further testing or not.
Thank you for the wonderful call. Appreciate it. We are out of time, and I want to thank everybody who called. And I particularly want to apologize to Martha, Diana, and David, who are still up there on the board, but who we don't have time for today. I can't understand, frankly, folks, why the first third of the program there was no one on, and then, as if by magic, everybody was on. So we're out of time. Thanks everybody who called in. Dr. Sankar Varanasi, thanks again for joining us. Underwriting support for Medical Monday comes from the hospitals of HealthQuest and HealthQuest Medical Practice Physicians offering primary and specialty health care in private office settings throughout the Hudson Valley. Health-quest.org for appointments. I also want to thank our engineer, Zach Malloy. Thanks to Tiffany Brown-Bennett for answering the phones today. Our producer is Patrick Donges. I'm Alan Chartok, and I have a last question on Facebook. I don't know if you can answer it in a sentence. Probably not. But Vaughnie says, please describe mitral valve prolapse. Does this condition make a person more likely to have a heart attack?
Mitral valve prolapse is an abnormal closing of the valve. It's not built normally. It does not necessarily increase the risk of a heart attack.
I love the fact that you answered it in a sentence. Okay, folks, stay tuned now for a lot more interesting programming right here on WAMC.